medicine and stuff. But should you tell them, no, I can't take it?
Let's talk, that's a separate, so I think I heard two questions. One is, what's the plan for pain medicine after this surgery? And then another question is, let's suppose sometime in the future, I have a serious injury and I need pain medicine. What should I take for pain in the months and years after surgery? So I have two questions there. Let's answer the first question that I heard, which was, what about pain after this surgery? What can we expect? Well, number one, we're doing a lower stress, lower trauma, lower damage to the tissue surgery, so we hope and pray and expect less pain after the surgery. Second of all, we're going to use a variety of drugs to treat your pain after surgery. If you think about it, many people know that the primary treatment for pain after surgery is a group of drugs called opioids or narcotics. Okay? Narcotics are like morphine and codeine and Dilaudid and Demerol and OxyContin and things like that. And the narcotics, interestingly, like the gas anesthetics, are terrific, commonly used drugs, but they have two issues. Nausea and vomiting, right? Narcotics, ever had codeine with nausea and vomiting? Yeah, codeine, nausea and vomiting. And number two, like the gas anesthetics, unpredictably, higher doses can stop your breathing. And with decreased breathing, there can be hypoxia or low oxygen, irregular heartbeat, and death. So we want pain relief, but narcotics have some side effects. So there's a whole area of research which we have taken advantage of called opioid-sparing anesthesia and analgesia. That's opioid-sparing, non-narcotic treatments of pain. If you think about it, in the brain there are circuits where the narcotics work and cause pain relief. And so researchers said to themselves, maybe there are other circuits that we can get pain relief from. And they found two other circuits, at least two other circuits. One is the NMDA, the N-methyl D-aspartate receptors, and the other are alpha-2 receptors in the brain. And both of these receptors, when stimulated by different drugs, decrease pain. And the drugs that decrease pain that act on those receptors do not cause nausea and do not cause respiratory depression. So we use a cocktail of NMD receptor agonists and alpha-2 receptor drugs to decrease our patient's pain. So you're going to have patches on, and you'll be given other drugs like the ketamine we talked about, which is an NMDA receptor stimulant, to decrease pain, to make you feel a little groggy, and to feel less uncomfortable. And to avoid using the need for rescue narcotics, so you'll have less nausea from the narcotics and less risk of the danger of depressing your breathing. Now, we still want to give narcotics when necessary. We'd like to give you enough of the other medicines so the amount of narcotics is decreased, so the danger of the side effects of narcotics are decreased. But let's now talk about the narcotics that we're going to be giving you as options for pain post-op. If you have no pain, you don't have to have anything if you don't want it. But you will have a pump with a button at your bedside that's armed with the powerful narcotic called Dilaudid, which you can take at any time after the surgery, and we encourage you to take advantage of it. Some people have the I'm tough, I'm John Wayne, it's just a flesh wound, I'll suffer, and we don't want that. Take the pain medicine, use the pump. It's only a very little dose, and so use that. It's available post-op. Number two is the powerful dose of Dilaudid as an injection is in the hands of our nurses. And it has to be there because we know you are all what we call the public. And giving you all the narcotics is dangerous in high doses. One morning, for example, I came in and a husband was pushing his wife's button saying she was kind of annoying me. And we said, sir, that's not what that's for. So we have to put relatively low doses in the pump that we give you because we don't know who's going to come in there and pump it. But the powerful dose is in the hands of the nurse, and so if the little dose that's in your pump is inadequate, then you call the nurse.
And it's mainly for that night at the hospital.
Yeah.
That one night. Afterwards, the pain comes.
Right. So in the hospital, let me go over this again. In the hospital, number one, you'll have a pump. Number two, you can call the nurses. And number three, there's also tablets of pain medicine you can take as well. Now, when you leave the hospital, it's very radical to be discharging patients within 1 day after major surgery. We have shown we can do it safely, provided we don't give you narcotics to cover up severe symptoms at the hotel. So you're allowed to leave the hospital as long as you feel good. If you have severe pain, you can come back to the hospital. In that case, we'll give you narcotics, but only while we monitor you and evaluate you closely. So it's a branch point. I feel great, you can go to the hotel or you can go home. I don't feel great, I want to have more powerful pain medicine, then you come back and stay in the hospital. So that's the story of pain medicine right after surgery. Does that kind of answer your question?
Yeah, well, I mean, I saw the people that had surgery last week, and I talked to a few of them, and there was no issues at all.
Right. Now, let's talk about the next question that I heard, which is, okay, I'm in trouble, I've gotten severe injury, I've had a burn, I've had a broken leg, I've got a gunshot wound, and I'm in real pain. What medicines can I take? Well, we don't recommend aspirin and Tylenol, but narcotics are fine. Narcotics don't have any damaging effect on the gut. Narcotics do have a risk of addiction, so they're not a good choice as a willy-nilly, I'll take them anytime I have a bump or a bruise. But for severe pain, narcotics are a great choice.
Except for gout.
They work pretty well for gout too, but you just can't use them forever.
Yeah, they just.
Well, afterwards, do not suppress the breathing, narcotics, or they always do?
They always are a danger. But you're much more likely to die from a narcotic excess as a heavy person than you are as you get thinner. So your ability to rely on narcotics gets better the thinner and healthier you are. The narcotics become much more dangerous the heavier, the fatter, the worse your lungs, the worse your breathing is. So good question, both of you. Thank you.
CPAP